My name is Elizabeth Partin, and this is my case study development for advanced clinical procedures. My patient is a 27-year-old female. Her ethnicity is multicultural but predominantly African American. She has 2 small children at home and no real support system. She also takes care of her mother and 3 younger siblings financially. The patient was recently treated for hyperthyroidism. Her thyroid was obliterated with radioactive iodine, and she is now hypothyroid as a result. Patient was a teenage mother, smokes cigarettes, and drinks heavily once a month, and suffers from anxiety. The patient's mother is a habitual drug user and has been the patient's whole life. She states that she never received dental care growing up because her mother never brought her to the dentist. Her only experience with a dentist has been extracting teeth due to caries. This is the first time she has had a job that offers dental insurance, and she is here for a preventive appointment. The patient's disease is hypothyroidism, and her condition is anxiety. Some special conditions are that the patient also smokes 1 pack of cigarettes per day and drinks heavily 1 time per month. She has no known allergies. Her vitals were within normal limits. Her medical assessment is that she is an ASA Class 2. She has had 2 cesarean sections, one in 2007 and 2011. She was hospitalized post both C-sections and post-thyroidectomy via radioactive iodine. The patient has also been hospitalized for alcohol poisoning twice in 2014. Since her disease onset, she has started Xanax for anxiety in 2011 and levothyroxine for hypothyroid in 2015. We are going to use caution when administering local anesthesia due to the thyroid condition and smoking tendency and the tendency to binge drink. This slide shows the medications the patient is currently taking. Both medications can cause xerostomia, and so caries is a definite risk for this patient. She also needs to avoid grapefruit and grapefruit juice for her Xanax, along with alcohol. Because the patient has mentioned that she does tend to use alcohol outside of moderation occasionally, it is good to remind her that the use of Xanax with alcohol is counter-recommended. The patient's intraoral assessment is that the face, head, neck, and lymph nodes all had no significant findings. The TMJ has popping and clicking bilaterally. The patient did mention that she tends to clench her teeth during the day, especially when she's stressed. No significant findings on the lips. The mucosa and alveolar ridge are generalized signs of inflammation. On the palate and oral pharynx, we noted nicotine stomatitis on the anterior palate. The tongue is coated and fissured. Calculus is moderate generalized with heavy localized in the mandibular anterior. Her plaque is heavy and generalized. There is moderate generalized stain with heavy localized on the lingual aspect of anterior teeth, most likely due to the patient smoking. Bleeding is moderate generalized. I believe the bleeding response is diminished for the state of the tissue due to the patient smoking. With the amount of plaque and calculus, I would expect it to be heavy generalized. Her occlusion is class 1 canine bilaterally, and the molar occlusion is not applicable due to missing first molars. Her PSR is 4-3-4 in the maxillary sextant and 3-2-4 in the mandibular sextants. Her probing depths are generalized 3 and 4, localized 5 and 6 in posterior interproximal regions. Her clinical attachment level is really adequate. No recession is present. The patient has no restorative work and has only ever had teeth extracted due to caries. Her missing teeth are 1, 3, 15, 16, 17, 19, 29, and 32. All are missing due to caries, other than the 3rd molars, which were extracted. She has active caries on 2 distal, 7 mesial, 8, 9, and 10 class 5, 14 mesial, 22 mesial, and 30 disto-occlusal. The oral lesions that are present are nicotine stomatitis in the mid to anterior palate. On the gingival assessment, it is noted that the gingival color is generalized marginal and papillary moderate redness. The gingiva is bright red with signs of inflammation on the lingual aspect of 22 through 27 and on the buccal aspect of 2, 4, 13, and 14. The patient also has generalized melanin pigmentation. The gingival contour shows that generalized marginal moderate bulbousness and flattened papilla, the papilla no longer filling embrasures in all interproximal areas. The consistency is generalized diffuse moderate sponginess, and the surface texture is the generalized diffused moderate smoothness accompanied by loss of stippling. There is generalized marginal shininess, increased severity of the shiny and smoothness on the lingual aspect of 2027, where a large supragingival deposit exists. The patient presents with generalized red to bright red gingiva in the marginal and papillary regions. The severity of the redness is increased in localized areas of 22 through 27 lingual and 2, 4, 13, and 14 buccal. The gingival contour is generally bulbous with a total loss of papilla in the interproximal areas. The texture of the gingiva is generally spongy with a loss of stippling in the attached gingiva and an increase in the shininess of the marginal free gingiva. The greatest severity of the shininess and loss of stippling is seen on the lingual aspect of 22 through 27, where a large supragingival calculus deposit exists. Here are some gingival images of my patient. The first shows melanin pigmentation and flattened papilla. The second, or center top image, shows lingual tobacco stain with heavy supradeposit on 22 through 27. The third image on the top row is nicotine stomatitis. On the second row, the far left, is generalized bulbous papilla and marginal and papillary redness. Then moderate maxillary lingual tobacco stain. And finally, on the bottom right is a generalized loss of stippling. The periodontal assessment shows that there is generalized 3s and 4s throughout the dentition with a concentration of interproximal 5 and 6 millimeter pockets in the posterior regions of the mouth. We can see that there are numerous teeth that have been extracted, mostly were due to caries. There's also generalized bleeding on probing, and special attention should be paid to the Class 2 furcation on tooth number 2. The patient's periodontal classification is a generalized Class 2 with Class 3 present for teeth 2, 4, 13, 14, and 18, which is 21% of the dentition. The reasoning and rationale behind this classification can be seen on the chart. As stated in the previous slide, the patient's ADA classification is a generalized Class 2 with localized Class 3 in teeth 2, 4, 13, 14, and 18, which makes up 21% of the existing dentition. The prognosis for this patient is fair to poor for the following reasons. Areas of Class 3 have less than adequate bone left to support the teeth, and there is a Class 2 furcation involvement. Areas of Class 2 do have adequate bone levels to support the teeth, but the patient compliance is doubtful due to smoking and number of teeth with caries and perio involvement. The short-term goals for treatment are that our PI be less than 10 is it. We want the patient to be flossing once a day, brushing twice a day for 2 minutes at each time. We would also like to reduce probing depths by 1 millimeter at our 4-week recall following the initial SRP. Long term, we would look to halt bone loss, not increase the number of teeth with furcation involvement, eliminate areas of BOP, no supradeposits on the mandibular interior, and we would like the patient to quit smoking. The modifiable factors that are present are the patient home care, frequency of office visits, bleeding on probing, signs of inflammation and active disease, and also smoking is a modifiable factor. Non-modifiable would be the areas where bone is already lost, furcation involvement, and the patient's disease and condition. This patient's treatment is going to take place in 4 different appointments. The first appointment is a comprehensive exam that includes dental charting, perio charting, an exam by the dentist, digital FMX, diagnostic intraoral photographs, full mouth debridement, and oral hygiene instructions. First, we reviewed the medical history. Patient has hypothyroidism that is treated. She has taken her meds today. Patient also suffers from anxiety and is medicated for that condition. The patient smokes 1 pack of cigarettes per day. She said the stress of caring for her children, siblings, and mother is too great at this time, and she is not willing to discuss quitting options. The patient also admits to heavily drinking 8 or more drinks 1 time per month or when she can afford a babysitter. The patient's baseline vitals were a blood pressure of 118/80, pulse of 64, respiration of 12, and a temperature of 98.6 degrees, which are all within normal limits. The comprehensive exam was performed by the doctor. A digital FMX and intraoral photos were taken. In the intraoral extraoral exam, it was noted that patient has nicotine stomatitis on the mid to anterior palate. This was explained to the patient that is completely reversible condition and has an excellent prognosis if the patient will quit smoking. The doctor diagnosed multiple carious lesions throughout the mouth. Those are noted in the treatment plan and on the dental chart. A full mouth probe was performed with generalized 3 to 4 millimeter pockets and localized 5 and 6 millimeter in the posterior and proximal regions. There was generalized moderate bleeding on probing, class 2 furcation on tooth number 2, and generalized spongy erythematous gingiva with moderate signs of inflammation. Patient's PI at this visit was 67%, and the goal for the next visit is 20% or less. 4 quads of SRP were recommended using chlorhexidine for irrigation with placement of local chemotherapeutic agents after SRP. Patient agreed to the treatment plan, but can only take limited time off of work, so she requested that 2 quads be completed at each visit. After the completion of the SRP, the dentist wants to address restorations. This time we did a full mouth debridement with the Cavitron and chlorhexidine for irrigation. Due to numerous carious lesions, patient was also given a food diary to track food intake and assess risk to be returned on the next visit. Patient has no dental knowledge, so OHI was very basic at this appointment and focused mostly on the disease process pertaining to bone loss and the etiology of caries. I demonstrated the BAS technique and had the patient demonstrate it back to me. Next visit, we will reiterate the disease process, demonstrate BAS again, and introduce flossing. The patient was prescribed ClinPro 5000 1 day to replace her dentifrice, and chlorhexidine 1 time per day to replace over-the-counter mouthwash. She was instructed to use ClinPro before bed and the chlorhexidine in the morning. Patient was given directions for use for both products, verbally and written instructions to take home. Next visit will be an SRP of the right side using the Cavitron and chlorhexidine. We will also do placement of Arrestin where the pockets allow, revisit OHI, and we will talk about the restorations for the right side of the mouth. Next visit was 1 week later, and that included an SRP of the upper right and lower right with 4 or more teeth per quadrant, an AMSA, PSA, and IA injection, oral hygiene instruction, 4 Arrestin placement, and topical fluoride to the right side of the mouth. Patient's vitals were reviewed, and they were all within normal limits based on the baseline taken at the first appointment. I examined the gingiva, and the signs of inflammation have visibly reduced since the last visit, especially on number 22 through 27 lingual. Patient stated that she has been using the ClinPro and the chlorhexidine as prescribed, and the patient has thought more about quitting smoking and how it can improve her oral and physical health. She's still not interested in quitting, but she did take a brochure from Tobacco Free Florida at this visit, which she had refused previously. Her PI improved to a 31%, and so the goal for the next visit is still going to be 20% or less. We revisited OHI. I had the patient demo the BAS and adjust her technique as needed. Then I demoed flossing to her and had her demo it back. and I instructed the patient that she should be flossing 1 time per day. Administered ESA, AMSA, and IA injection. Applied 20% bupivacaine to injection sites for 20 seconds. The drug of choice for these injections was a 3% bupivacaine, and I used a 27 short needle and 3/4 of a carpule for both the PSA and AMSA, and then a full carpule using a 30 long needle for the eye. The patient confirmed profound anesthesia, so proceeded with the SRP for the right side using a Cavitron with chlorhexidine for subgingival irrigation, and then hand scale to finish. Then administered Arrestin to 4 sites, tooth number 2 mesial and distal, and 4 mesial and distal on the buccal and lingual aspects. Instructed the patient not to floss in the area placement for 10 days, and then applied a fluoride varnish to the upper right and lower right quad. Advised the patient to follow up directions for the fluoride varnish, and then provided written directions for Arrestin and fluoride for the patient to take home. We discontinued the use of chlorhexidine as a daily mouth rinse because of the tissue and BOP improvement, and instead put the patient on a 1 week per month schedule with chlorhexidine until the BOP has completely remediated. Next visit, we are going to do the left side for the SRP. Okay, so third visit, which is going to finish up the SRP, will be the SRP left side for 4 or more teeth. The AMSA, PSA, and IA injections. Our last OHI and 6 sites of Arrestin placed, along with the topical fluoride for the left side of the mouth. Vitals and medical history were taken. Everything was within normal. This patient has taken medications as directed. She did review the literature from Tobacco Free Florida, and she has been in contact with the HELP hotline. I asked the patient if I could offer any support. She said not at this time, but I will follow up again when she comes back in for her follow-up appointment. PI at this visit was 22%, and the goal for the next visit is going to be 10% or less. We revisited the OHI. Patient has been using the BASS technique and has been doing great with that, but she did say that she's having trouble finding time or motivation to floss. So I gave her the Reach Access Flosser, because it's easy to use when she's in the car or on her lunch break. It might give her a little more motivation to floss at least once a day. Same injections and technique used as on the right side of the mouth. We just switched over to the left side. And then on this side, Arrestin was placed in 6 sites, to 13, 14, and 18, mesial and distal, buccal, and lingual for all teeth. Same instructions as last time, and then the fluoride varnish was also applied on the entire left side, and we still gave patient the written directions to take home for. This last appointment is taking place 4 weeks after the completion of the patient's SRP. It's going to be her first perio maintenance visit with nutritional counseling, tobacco cessation, and a restoration consultation. Medical history and vitals are all within normal limits. Nothing has changed since her previous visit. She's taken all of her meds prior to today's visit. The tissue has visibly improved since completion of SRP. It's now generalized coral pink, BOP is remediated, and pockets have all generally decreased by 1 millimeter. PI is at 12%, so we are saying that the goals for the treatment were met, and patient can now bring maintenance appointments at a 3-month interval. For this appointment, I did the Cavitron and hand scale with a polish and floss for all quads. And then the patient also stated that she has started to cut back on smoking. Tobacco cessation was provided at this appointment, and the patient set a quit date for December 1st of 2016. I have made a commitment that I will call the patient on their quit date to offer encouragement, and then every other day after that until the patient decides that she needs further contact. The patient stated that having her teeth look so pretty made her realize how damaging the smoking had been for her health and for her self-esteem. The patient also returned her food log on 11/10/16, so that food information was entered onto choosemyplate.gov, and reports for nutritional analysis were generated. At this visit, we discussed these. The patient has a significant caffeine and sugar intake later in the day. She recorded 4 or more cups of coffee and 2 or more energy drinks per day. The patient stated that she is too busy and doesn't have time for adequate sleep. That is most likely the cause for the frequency of caffeine and sugar intake, which is also likely the leading cause for her rampant caries. The patient was advised that these risks associated with the amount of sugar and caffeine she is taking in, and she agreed to intake of those beverages by half and replace those liquids with water. I also provided a sample menu, and that should increase her vegetable and fruit intake and reduce her fermentable carbohydrates. The patient was also advised to make a list of tasks to accomplish throughout the day and prioritize them to avoid going to sleep so late and then relying on caffeine and sugar for her energy. The patient also met with a treatment coordinator to schedule her restoration appointments. So her next visit is 1 week from today. She will address the restorations for 2 distal, 7 mesial, and 8 and 9 class 5s. This slide shows a little more in depth some of the home care recommendations that were made for the patient. Most of these are covered in the treatment notes, but she's using chlorhexidine 1 week every month to reduce bacterial load. I recommended an electric toothbrush, especially a Sonicare or something similar that has a smaller brush head that she could adapt a little bit more easily to her mandibular anterior. I also like the Sonicare because it has a 2-minute timer in, and it will just shut off after she's done with the 2 minutes, so it takes the guesswork out of it for the patient. I also want her to set that toothbrush to the whitening setting or add extra 30 seconds depending on which brand she's using, and spend that time focusing on the lingual and facial aspects of her mandibular anterior. I'm recommending Crest Pro Health Advanced Gum Protection for her use as her regular dentifrice, and then once a day after she's done with her afternoon energy drink or coffee, whatever it may be, I want her to brush with a paste of baking soda and water just to help reduce the pH of her mouth. She started with traditional floss, but then switched to the Reach Access Flosser just because she's more likely to use it. And as her dental hygienist, I just want her flossing with something once a day. So if that's easier for her to use, then I would like her to use that. She's not going to use any interdental aids at this time. She is missing her papilla. It doesn't fill the embrasures, but her spaces aren't that large, so traditional is going to work well for her. And then specifically, I want her to avoid mouth rinses that contain alcohol. These will dry out tissues anyway, but with the alcohol content of the mouth rinse and the tobacco use that she has, it's really going to be detrimental to her tissues. And then I also want her to avoid using chlorhexidine more than prescribed because that will have a propensity to build up calculus and stain. And with the smoking, she already has that propensity, so we really want to make sure we only use it added. And then lastly, a little bit more in-depth look at her nutritional analysis. I want her to add water to her diet since she is severely lacking in that. And then not only is she lacking in water, but she's replacing her liquids with high-calorie, high-caffeine beverages that are also very acidic in nature. I want her to add more green leafy vegetables and then also more high-fiber fruits. I would like her to omit processed grains and processed sugar from her diet. There's a lot of empty calories that she's eating, and it's actually contributing to the sluggish and tired feeling that she's having. And then to avoid in her diet, I'd like her to cut her caffeine intake in half. With her current lifestyle and working and taking care of many family members, it's really not realistic for her to cut caffeine out completely. But if she could cut it in half, that would really help her greatly. I also think getting 8 hours of sleep every night is really going to help her because right now she's overcompensating with caffeine and sugar to make up for that lack of sleep. It's also really important that this patient avoid grapefruit. It does interfere with both of her medications, so that's something that she really needs to be careful with. I would like her to start a daily multivitamin, but check with her general practitioner before using it just because her medications are needed every day, especially the levothyroxine. She needs that to function, so that needs to take priority, and she can check with her general practitioner about any vitamins or supplements. Vitamin B would be great. It can help with metabolism and increase her energy, so that would be great for her. And then also a nicotine gum might help to kind of reduce those cravings as she's starting to quit smoking. So that is it. That's my whole case study. Thank you so much for listening.